and Justin has graciously agreed to come and do a sepsis talk for us. So um, we're going to do some defining sepsis updates, and Justin, you can go ahead and get started.
All right, thank you. And so kind to say it was gracious. I believe I was begging and pleading for the opportunity. But thanks everyone for joining us to talk a little bit about sepsis. And kind of the thought here is to look at the different aspects of documentation and treatment and how we find a balance in all of the different metrics that we're dealing with. So no financial disclosures or conflicts of interest. The kind of overall agenda is to first touch base on the initial response and management of suspected sepsis. Throughout this, I want to continually emphasize that treatment is what we should be worrying about first. Any of this question about documentation is kind of a second aspect in my mind. But once we've kind of reviewed the response and management, then talking about how we balance ensuring that we aggressively manage sepsis, given the severity that it can be, but make sure that we are capturing it adequately so that we have appropriate quality metrics and hospital payment. From there, spend some time reviewing the UAB definition of sepsis and documentation best practices. And I was going to touch some on future updates, and I actually forgot to put that slide in, but I will mention it all the same. And so kind of my takeaways to lead with is to say patient care will be first. If you have a patient who is unstable, focus on resuscitating that patient. If you think there's a possible infection, using the sepsis bundle or code sepsis process as necessary. But once that initial resuscitation has taken place, take your time to step back each day as you're preparing documentation and recognize that diagnoses evolve and that as you go through a hospitalization, we may recognize new ones or we may rule out things that we had on our differential to begin with. And this certainly applies to sepsis. One of the challenges that I think we, particularly as the hospice group, face going forward is trying to differentiate between what's a localized infection in which the patient has SIRS criteria, but they're not really sick or toxic, and therefore kind of meet more of a definition of simple infection, but truly aren't septic. And then also thinking about when you have sort of complex interactive comorbidities and an infection develops, is that infection what's driving things and therefore the patient was septic, or we often talk about sort of end stage malignancy where the entire body is sort of shutting down, and because you have no skin barrier, an infection will get detected, but really it wasn't the infection that was driving those final days and hours of the patient. All right, so what is sepsis? Now, we talk about SEP1, SEP2, the SEP3 definitions, but those are really all efforts to operationalize sepsis and give us some sort of system to mark yes or no sepsis. But kind of stepping back, consistency across these definitions is to say that sepsis is an overwhelming and dysregulated immune response to infection that can lead to organ damage. It is an overactive and toxic response, and it's a medical emergency. And so thinking about these concepts of dysregulated response, toxic, medical emergency, these are the concepts that we want to get at to capture, is this an infection with a little bit of a high heart rate and a white count of 14, or is this a really sick patient who has the risk of, if we don't aggressively manage it, ending up in shock, ending up in an ICU? And so I think we all kind of recognize this, but things to think about in terms of developing sepsis is new hyper or hypothermia, change in mental status, a patient who is extremely ill or sort of symptoms are out of proportion to how they feel, and then of course having a concern for infection. When sepsis is suspected, we have a sepsis power plan, which helps you capture the lactate. If it's elevated, to repeat that lactate, collect blood cultures, administer antibiotics, get the right amount of fluids. We encourage reassessment after those fluids to see, did the patient respond appropriately? Has their blood pressure come up? And then lastly, vasopressors. There is some conversation about the reassessment note, which we have encouraged. And part of that is certainly good clinical practice. Like, you have a sick patient who you're managing for sepsis, it certainly makes sense that you're going back and reassessing. The reassessment note has language built into it that if that patient were to meet shock criteria, it helps us then meet the SEP1 CMS bundle, which is one of the quality metrics that the hospital gets measured by. It's not technically required for all patients, but in the sepsis debriefs for all of our code sepsis cases, we include it in there as a sort of approach and use it in all cases, so that you're not trying to remember the distinction between, well, did this patient have a lactate of 3.8 or 4.1, and would that make a difference in whether they needed this reassessment note? One of the things, to go back to this manage first, worry about the diagnosis to a degree later, is to think about that sepsis management is our system one thinking. It's more unconscious, instinctive. You see a very sick patient in front of you, you have a concern there's an infection, and we're going to the sepsis bundle and collecting our lactate, antibiotics, blood cultures, fluids. It's then 6, 12, 2 days later where you can sit back and assess the data in front of you. How did they respond? What cultures do we have? What imaging did we get? And do we still think what we saw was sepsis? And so that brings us into the system two thinking of being more conscious and deliberate, having the time to step back and reassess our diagnoses each day. So I kind of alluded to, there's this balance that I'm trying to find as I reach out to talk about managing sepsis. So first and foremost, you've got the patient in the center, and we want to keep it about the patient. And so early recognition is always foremost in my mind. If there's a concern, manage it. You can always peel back later. We obviously have a hard time rescuing someone once they've reached shock state if we haven't been aggressive up front. We know there's effective treatment, and the earlier the initiation of that treatment, better the outcomes. But then we want to start being able to capture what was the severity of this patient's illness, both in terms of what comorbidities do we highlight, but also how do we describe them in the chart? Were they acutely ill? Were they working to breathe? Or were they non-toxic? And so having someone documented as non-toxic or no acute distress, and then saying they're septic, is a discontinuity that's going to raise questions from someone reviewing the chart. Related to the severity of illness is kind of understanding what the risk of mortality is for an individual patient. Of course, as much as I want to promote upfront aggressive antibiotics, we have to recognize the role of antimicrobial stewardship, resistance. And so we do want to treat, but reevaluate and withdraw those antibiotics if they aren't indicated. And now we get into the stuff that doesn't directly impact our day-to-day, but does reflect who we are as a group and who our organization is. And that gets into our quality metrics, which will relate to when our charts get submitted, our payment denial happening. We do have, I haven't been able to get access to have a good understanding of the percentage, but some portion of our charts that go out as sepsis do get denied and get downgraded. And depending on when that happens in the process, the hospital has to pay back money for cases that the insurance companies come back and say, we're being too aggressive in calling sepsis, and it really was just a UTI. And then we'll kind of also touch base on the clinical documentation integrity group and the queries that we receive and will be receiving moving forward. So this is the observed to expected mortality for patients admitted to the hospitalist group and discharged with a diagnosis of sepsis. Sort of goal would be to have an observed to expected mortality of 1. The numbers right now are a little hard to fully understand because of the impact of COVID, particularly when you add in the fact that for several months we were admitting patients but not caring for them because they then went to the Tinsley surge services. But overall, we do perform well. We're right around that 1 mark, but we probably have some opportunities. And at least part of that, and often many times most of that, is what we're capturing and coding. There are a few cases I see where there's clear clinical opportunities that were missed. We are pretty good about getting the bundle. If people need fluids, we get them the fluids. But if we have someone who comes into the hospital with a relatively low risk of mortality and they die of their metastatic cancer, but we tack a sepsis diagnosis on there when really it was a multi-system failure, that can impact our O to E, even though we're kind of providing best clinical care. And so it's just thinking about how we compare with other organizations, which is where this comes in the end. And to give us a little bit more feel of how we are comparing to others, this first chart on the left speaks a little bit less to us because it's looking specifically at cases of septic shock. But what I'd done is looked at all of our discharges that had a shock diagnosis, and nearly 50% of shock cases discharged from UAB carry a diagnosis of sepsis. When we compare to the 2 green, Houston Methodist and Mayo Clinic at the very bottom, they tend to always be a leader in the observed to expected mortality. And so there is something that they're approaching differently in cases that they call sepsis and cases that they don't. I will admit there is no linear relationship here. So the fact that we're higher doesn't statistically mean it's worse, but it certainly helps me understand that there's probably opportunities for, compared to others, us overcalling sepsis as an organization. The other chart here is from the Pepper report, which CMS looks at a number of things, but included in that is looking at, for cases of simple pneumonia and sepsis, what percentage of those cases combined are diagnosed as sepsis. And you can see kind of that we have always been towards the sort of 80th percentile. Now, some of that makes sense as a big tertiary center. We're going to have more of this than a small rural hospital, which will have to transfer many of these patients. So that we're towards the upper end isn't necessarily a concern, but we can see since 2018 that we have steadily crept and are now pretty consistently above the 80th percentile, which is, again, one of those warning systems of, are you overcalling sepsis? And it's going to raise concern from external parties. And so coming back to that conversation, sepsis, overwhelming, dysregulated immune response, infection that can lead to organ damage. It's an overactive and toxic response. It is a medical emergency. And so this is to say that definition doesn't say anything about SIRS. It requires more than just the presence of SIRS. We talk about SIRS as a way to operationalize, but I think we all kind of can recognize that You may meet SIRS with a heart rate of 100, but someone with a heart rate of 100 and someone with a heart rate of 130 could be two completely different patients, and that 100 might be normal. You can walk into an urgent care with a sinusitis with a heart rate of 100. You don't need antibiotics to begin with, and you don't need to be admitted to the hospital, depending on which ED doctor you see. Now, a septic patient is someone who is unstable or puts the hairs on the back of your neck saying, I'm concerned that this patient could turn bad in the next couple of hours. I want close eyes on them. I want cross cover to come check in on them. I want to do a little bit more, because this isn't just someone who came in a little confused because they're dehydrated, and I think we also found a UTI. And so that brings us to the definition. And the first four rows here are what has been in place at UAB for at least over a year. And so we kind of have our three categories of sepsis: your sepsis without organ dysfunction, your sepsis with associated organ dysfunction, and then septic shock. And to meet these as sort of a minimum, you have to have a confirmed or suspected source of infection. You should be able to show two SIRS criteria. And once you're getting to that organ dysfunction, either having elevated lactate or end organ dysfunction as measured by SOFA criteria, or shock where you're having persistent hypotension after resuscitation or a lactate greater than 4. What we're adding to this definition to try and speak to some of this nuance is to say that the SIRS criteria are above and beyond what you would expect for a standard infection, and it's not explained by another condition, or you don't really feel like it's being driven by the infection. And admittedly, this is a nebulous definition, and it's in the eye of the clinician providing care for the patient. And that will then tie us back to have our documents tell a story of the patient. If a case comes to me for review to decide, is this or is it sepsis, I know I haven't been at the bedside with that patient. But if you're putting in there that the patient looks sick and toxic and using those terms, then I'm going to say, yeah, they thought this patient was septic. If you say, yeah, they were talking to me in full sentences, but they've got acute hypoxic respiratory failure, I'm going to say that doesn't make sense to me. We've got to, in this case, probably send you a query to say, clarify, like there's a conflict here. Help us understand what the resolution is. And just to review, for the SOFA criteria, you're looking for an increase in the SOFA score greater 2 points or greater from baseline. So, certainly creatinine is always a good one to think about in terms of baseline. If you have a mild CKD3, then you're looking for, in this case, a creatinine perhaps above 3.5 before you're really hitting that SOFA score. The other category to really hit on is thinking about that respiratory failure. After the CDI group is tackling sepsis, looking at acute hypoxic respiratory failure is going to be their next area. I will say that I have never fully understood what the threshold is between someone was hypoxic and someone was in respiratory failure. My searching has never really found a good definition, but I have found working off of the SOFA score as a good approximation. Now, the true SOFA score is based on your PA2 over FiO2, but if you walk through the oxygen dissociation curve, you can come up with an approximation that says someone who is on 3 to 4 liters of oxygen may be meeting that criteria. Again, if it's above a baseline and they've got the increased work of breathing to go with it, which of course, COVID has made my year frustrating in addition to the actual management of it, because you have these people with so much oxygen, and sometimes they're perfectly happy with it and don't realize that they've got an O2 sat in 60. So how do you document that, and how do you call that? But we will try not to delve into that, and keep our head in the sand and hope that it keeps going away. And so when you've come to your diagnosis, putting it into the chart, the ideal and really the necessity, I should say, the necessity is to have everything linked and paired together. So if you've got sepsis from a community acquired pneumonia, we encourage you to go ahead and include in that statement the without organ dysfunction, so that you are making it clear to CDI, to coding, that there isn't some organ dysfunction to it. And, the patient could have had a small AKI that either doesn't meet SOFA criteria, or you didn't really feel it was from an overwhelming response. It was, they felt bad, they didn't drink for a couple of days, and you didn't really feel like the two were linked. Again, you can argue that either way, and you just kind of have to support it in your documentation, because I think it's also perfectly reasonable to say someone's sick. The infection made them lose their appetite, stop drinking, and therefore cause the UTI. It just has to have something in the document to help us understand what you as the provider are thinking at the bedside. Similarly with organ dysfunction, stating explicitly what is that organ dysfunction, and then what's the infection. So an example could be sepsis with metabolic encephalopathy secondary to E. coli UTI, and then lastly septic shock. And if information changes, you pick up a patient and review the chart and feel like the differential up to that point was not sepsis and you want to rule it out, you can put that in. Once it's in the chart, as long as sepsis isn't put back in, it only has to be stated once. But if diagnoses are dropped and aren't really clearly addressed, that is something that will potentially bring a query for clarification. So some things to think about, particularly in the early days of a hospitalization, and we're actively working up and trying to identify the diagnosis. You can certainly use your sepsis with or without organ dysfunction and make that as a primary diagnosis. Of course, that means you do have to more explicitly make sure you state the sepsis ruled out if that ends up being the case. Another option is to do something like a concern for sepsis, possible sepsis, recognizing that those words should be addressed before the final discharge. So having a concern for a couple days is appropriate, but somewhere day 2, day 3, we should have what we hope is a good picture and be able to say, yes, it's sepsis, or no, it wasn't sepsis, and address that. And then the other thing, especially if they're more of a borderline case and you want to make sure we acknowledge the SIRS, which are important, you can do the SIRS due to infection or SIRS due to a non-infectious process. One of the things that I learned in the last couple of months that I had not previously known is that documenting SIRS due to a non-infectious process, so say SIRS due to AFib or SIRS due to heart failure, is what would be called a CC, we'll say a CC. There's certain conditions that are CCs and some that are MCCs, which impact payment on the back end. So having that documented does speak to severity of illness, risk of mortality. And so it is important to capture that and include that in the documentation. And to kind of try and summarize statements that I've made a couple times to this point, the that table we've presented for sepsis for many of our entire careers has always kind of treated sepsis as a simple arithmetic. You find one SIR, you find a second SIR, you find an infection, you call it sepsis. And really, I think that is making it too simple. It really isn't a checklist, but it is more about the overall sense of the patient, showing that they meet those ideas that you thought they were a medical emergency, you thought they were having a toxic response, and having that show up somewhere in your documentation to tell that story. So before we step in, because we'll kind of transition a little bit, I want to pause and ask if there's questions about any of this to go over more and talk about the definitions.
I have a question about the septic shock definition, because I've only been able to see it's someone who's hypotensive, not responsive to fluid resuscitation and requiring pressors, but I'm not as familiar with only having this lactate greater than 4 being like part of, I guess, that definition. Is that something new? Do you have a reference to be able to review? You can shoot me an email about it.
Yeah, I can shoot you an email. I'm in a similar boat with you, that a lactate greater than 4, especially on initial presentation, does not make sense to me as a shock criteria. But there is a reference for it. I generally myself don't use lactate to define my shock or to define my organ dysfunction. But it can be, and I actually went back and forth with the CDI program as they're going through this. And for a while, we had taken lactate out of the definition that we were getting ready to update and roll out, because to me, it's more about a sign of hypoperfusion, not really organ dysfunction. But there are interpretations to say that that hypoperfusion is a sign of your circulatory system or your circulatory organ being dysfunctional. But yeah, so I it's there. We can technically call it if you've got support for it. And so we've gone back and forth and it's now included, but it's not something I feel strongly about. All right. So to touch base on clinical documentation integrity, I hope we will be hearing more specifics as things go forward. But I can say that the program is undergoing a review, a redesign, and they're doing a lot of training with the nurses. And so we will be seeing new approaches to their queries moving forward. And ideally next week, although I suspect it's going to be a week later than that because they're waiting on me and Dr. Taylor to review, and neither of us has gotten to it yet. But there will be updates to the sepsis queries that will be coming out sometime in May. And then, as I alluded to, they plan to target acute hypoxic respiratory failure after that. But they will be working through their armamentarium of queries and updating. And I think that you'll notice sort of 2 changes. One, they should be structured more clearly to make it easier for us to identify the clinical criteria that they have seen in the chart that would either support or argue against whatever the diagnosis in question is. And then 2, probably some more nuance in the answer solutions, such as, this was sepsis or this was SIRS with an infection, but not toxic and septic, to try and help provide you with the options that would speak to the complexity of a clinical situation. And, just to sort of explicitly state, the goal here is integrity of the chart. the only right answer is the answer that describes the patient that you are charting on. If you felt the patient was sepsis, put sepsis in there. If you felt it was an infection and not really septic, but sepsis had come in and out of the chart and we need to rule it out, do that. You really, I talk about the financial aspect a little bit, the quality aspect a little bit, but in the end, I'm confident that we and UAB are providing high quality care. So if you are documenting what you see and what you managed, the quality metrics will follow with that. I don't want you to try and figure out how to game the system, and if I put this, we'll get more money or we'll get dinged with CMS. Like let's not get into those games. This isn't a game. This is patient care. But at the same time, we do need to be cognizant of what we write and what we say. So for the next 15 minutes or so, we will walk through some cases. Before I do that, so that I don't forget the sort of fourth objective of highlighting future things to come. The CDI update is part of that, but the other part is to talk about the DART system. So DART stands for Detection and Response Tool, Detection and Response Tool. And this is a program developed initially at Mayo and then spun out into its own system. And it is to aid in early detection of possible sepsis and to support administration of the sepsis bundle. And so what the system will bring is it will take away nursing having to manually document the Q-sepsis score that they currently document. This will be able to automatically gather that information. As we roll out, we will be able to tailor the algorithm for each sort of unit. So right now we're focused on the emergency department, but after that we'll be looking at GISO, S9, and P9 most likely. And so we may have a slightly different algorithm for a primarily surgical unit than you're going to have for your general medical units. And then once sepsis is suspected, it will, by the algorithm, it would provide a notification to nursing. And if they, know that this is a hematologic patient that is not septic, this is part of their natural course and they're responding to their treatment appropriately, they can sort of silence that alert and that's the end of it. However, if there is any concern or they're not sure, then they can take it to the primary team, who once again can look at that case and say, yes, there's enough concern and I want to start management for sepsis, or I don't think this is sepsis, I think it's decompensated cirrhosis. And there will be a box that will say this is decompensated cirrhosis, and then that will essentially turn off the algorithm for, I believe currently it's 6 hours, so that we're not getting repeated alerts. And then if sepsis is suspected and treatment is initiated, it will monitor the collection of lactate blood cultures, delivery of antibiotics. And if those things aren't happening, provide a notification to the appropriate party. So if it's not ordered, it will come to the orderer. If it is ordered but not administered, it would go to the administrating party or the nurses. Similarly, it will, based on the presence of hypotension, give a notification for a need for fluids. And if that hypotension persisted, then give a reminder for vasopressors, although I think we turned off the vasopressor notification because that's not really something I've ever seen happen where we have someone who needs pressors and isn't getting it. So I don't want some errant alert that's not going to provide any information. So that we, like all technology things, is going much slower than we had hoped, but we are aiming for July to be able to go live in the emergency department, and then from there would start developing the acute care algorithms and hopefully start that in the fall. I hope we all saw the announcement about the Cerner upgrade where we get nice pretty colors on our chart tabs in the middle of June. And so HSIS won't allow any changes to the system outside of that Cerner upgrade for basically 15 days before and 15 days after. So no changes for the month of June except for purple and orange tabs in our chart. All right, so to talk about a first case, and this is thinking about kind of a community-acquired pneumonia. We have 75-year-old, does have a known history of ILD, some hypertension, resides in the community and presents with vitals that we do have a heart rate that's elevated at 105. Initial respiratory rate's 24 and is placed on 2 liters nasal cannula to maintain a SAT of 94%. Blood pressure is 110/65. It's documented that the patient is speaking in full sentences, no respiratory distress, alert and oriented. White count is 15 and lactate is 2.4. Gets an initial gets the oxygen, some fluids, and is started on cap coverage. And so, is this sepsis? It certainly could be, and many of us currently would call this sepsis. She's patients meeting multiple criteria. We've got heart rate, respiratory rate, white count. Lactate is a little elevated, but at the same time, at least the physical exam gives me the impression she didn't feel well, but I don't think anyone thought there was an urgency that something devastating was about to happen with this patient. So in that case, this would be something where I would say this isn't sepsis. It's a community-acquired pneumonia, did have a lactic acidosis, did have 3 out of 4 stirs from an infection, but they were not septic, given that what was present is basically expected for the patient's illness and comorbidities. Another thing is, lactate resolves with a simple fluid bolus. Things are responding quickly, and we give 2 days of IV antibiotics and then transition to oral and DC home. And so even if the patient had looked sicker in the ED and you did think they were toxic and potentially septic, I would posit that someone you look at and they were able to go from ED to home in 2 or 3 days probably wasn't septic. They may have been at risk for it, and you may feel it's appropriate to say they were sepsis without organ dysfunction based on how they look. But I think you could also take that step back and say they were at risk for it, but responded very quickly to therapy and did not have sepsis. Again, as long as there's clinical reasoning that is understood, then there's not an issue. It's just when there's not a whole lot of clarity of what the clinical reasoning was, or there's conflicts between different diagnoses and physical exam. And so, to talk about how do we decide, is this sepsis, is it not? Considering the entire clinical picture, the patient may meet criteria for sepsis, but if they're not looking sick, the observed criteria likely represent the natural response to illness. I'm going to put out there that a short hospitalization, leaving out they deteriorated so quickly that they died, but a short hospitalization to home is unlikely to be associated with sepsis. And you can initially think sepsis and then see that they respond quick to treatment and then rule out sepsis after that. Any questions? right. Kind of a similar type of story. UTI, resides in a nursing home, has a fever, a little bit of a tachycardia, some confusion based on ED documentation, but by the time we come down to do the admission, it's back. Mental status seems to best be back to baseline. No flank tenderness. This suggests an upper tract infection. Again, a little bit of a white count, possible AKI with the creatinine of 2.5, some hyponatremia, and again, that mild elevated lactate. Fluids, antibiotics as our treatment. And so again, here, I'm going to put out that this was a UTI, but not necessarily sepsis. Lactic acidosis is present. We had a pre-renal AKI, but I think in my mind, it's not kind of an AKI because there's this drastic cytokine like storm, ATN developing. They were a little dehydrated. The creatinine was up. We gave some fluids, and it's completely back to baseline when we repeat labs in 12 hours. That just is hard to sell as a really sick patient. Yes, I think that was kind of my points for that one. And again, things that may have driven you to think more sepsis or push to document this as sepsis. If the patient had already been treated for 3 days with Bactrim and failed to respond to that initial therapy, or they come in and the renal function plateaus for a couple days before it improves, or actually gets worse before it improves. And if the confusion persists through that first day of admission. And then kind of hinted at before, the degree, I guess, of the SIRS. Like a heart rate of 95 is one thing, 120 is another. And so is this more of a simple tachycardia that, yes, should raise your concern? You want to manage these patients, but really they fortunately were here early enough. We got early treatment in, and we were able to prevent the sepsis from developing. I have my title buried under the pictures. Cardiac versus pneumonia. Oh, hospital medicine. I was just on HSP3, so this was every morning. So 60-year-old, known HFrEF, CKD stage 3, comes in tachycardic, a little tachypnic, requires a little bit of oxygen, blood pressure of 100/55, could be low, could be normal, happens to appear to be an AFib with an irregular heart rate, crackles in bibasilar lungs, pitting edema. Labs, a little bit of a white count, lactate is within normal limits, does have a troponin elevation and a creatinine of 3.0. Viral respiratory testing is negative. Our chest x-ray shows bilateral patchy opacities, which is probably pulmonary edema, but can't rule out a consolidation. And your EKG confirms AFib with a ventricular rate of 110 with no ischemic changes. Oxygen's initiated. The ED documents that they declined to give fluids for sepsis resuscitation because of the heart failure, but do go ahead and give CAP coverage. And this is partly here to touch base on this idea of AFib and how it impacts your interpretation of SIRS. And unfortunately, this is another where you could ignore the heart rate as a SIRS criteria and all patients with AFib if you felt that was clinically reflective. I, again, don't necessarily think that's always the case. Like if I'm seeing someone who we know has had basically stable AFib, lives in the 80s or 90s and is almost always well controlled, and they come in with an infection and they're now an RVR, I'm going to blame the infection for that. Like, you took something that was stable and you took it out of control. Now, if we piece this patient's story together and they're rate controlled, but do actually live 90 to 100, and now they're 110, well, I don't think you've taken something and taken it out of control. And to me, that would be how I would start to think about, is this a heart rate that meets STIRS criteria because of AFib or because of an infection, even though there's AFib present in both? So, documentation should, note you've got 3 out of 4 SIRS, and you could likely say that this was secondary to heart failure and AFib, and management is probably going to focus on diuresing, and you may or may not continue antibiotics depending on how you feel about the clinical presentation. I think after hypoxic respiratory failure, this concept of type 2 NSTEMI will be another focus. Honestly, we see variable documentation within our cardiology colleagues, so I'm not sure what we are supposed to do. And I'm going to skip over that part because that's putting my nose in areas that just aren't what I'm focused on. All right, is this my cirrhosis case? Oh, takeaways. So, so just to say, again, if you have a concern, treat the sepsis. I definitely want to say sepsis is a medical emergency. If it's crossing your mind and you feel that there's a possible infection, go ahead and treat it, and then use the type 2 thinking a day or two later and assess the picture when you've got more time and rule in, rule out, continue, discontinue antibiotics. When you do have multiple competing sources for SIRS and organ dysfunction, if there's more than one etiology, it is okay to say that that SIRS criteria is from some other etiology and not due to the infection. This is less, I think, something we see, although we certainly see it with heart failure and cirrhosis. It becomes more complicated in shock cases in the ICU, where trying to determine, is this from their bleed? Is it from their cardiogenic? Is it from the possible incidental pneumonia because they aspirated at some point questionably? That is kind of where, just because the STIRS criteria are there, we don't have to assign them to the infection first and foremost. And often that seems to be the approach. And when you think the infection is the driving cause, that's the appropriate thing to do. But if the cardiogenic shock is the driving cause and the aspiration from when they coded just happens to be there, well, that may not really be that the sepsis is driving this clinical picture, and you shouldn't call the infection sepsis. All right, here's our cirrhosis, and I'm pretty sure we can get through this one. So 45, decompensated alcoholic cirrhosis, known varices, stage 3 CKD, vitals, heart rate of 110, blood pressure of 95/60. They're altered, cannot maintain attention, distended abdomen, does have a fluid wave, it's tender to palpation. And so paracentesis is done, and it is positive and suggestive of SBP. Other labs include a white count of 16, lactate of 3.2, creatinine of 3, and platelets of 75. So the platelets of 75 would potentially meet SOFA criteria for organ dysfunction. In this case, the creatinine doesn't because of the baseline. But again, the platelets for a cirrhotic are probably also baseline and may not be. But so you appropriately place the patient on antibiotics, lactulose, and in this case, we did give them fluids. although we probably wouldn't have in a cirrhotic. Over about 2 days, patient's improving in mental status, transitions to PO intake and PO lactulose. Lactate slowly improves in this case because of sort of delayed liver clearance. Fluid cultures do grow E. coli, so we do have a confirmed infection. Eventually, the patient has an episode of hematemesis, has some hypotension from probably vagal component, and we go ahead and broaden out the antibiotics for concern that is there a new sepsis developing? Certainly an appropriate initial response. Collect new cultures, transfused, and they're transferred to the ICU. Fortunately, there's continued deterioration. They become encephalopathic again and uric as kidney function declines. No further bleeding. Repeat cultures or no growth. Has increasing vasopressor requirements and eventually care is withdrawn. And so this is one of those shock cases that is more of a challenge of how to piece it together in an ICU. There's appropriate concern for infection, but you've also got hematemesis, possibly new hemorrhagic shock, and you've just got vasodilatory shock from decompensated cirrhosis. And where's our infection? Like we have a precipitating cause of something that isn't entirely an infection. And the other thing, although this starts to get a little bit more into the thinking about quality metrics than thinking about care, but is also to kind of ask yourself, was there something about my initial care that wasn't correct? We managed the presenting infection well. It was pan-sensitive E. coli. They got ceftriaxone. And then you have an acute decompensation. If you can't really prove an infection, even though you've got a right to be clinically concerned, especially when you've got another cause for it, why tell the world that you mismanaged this patient and let them develop sepsis while they were in the hospital? Again, if that happens because they did have a wound that got infected, or they did have a major aspiration event that caused their clinical deterioration as opposed to being a sequela, we need to acknowledge that. Like, you don't hide those things, but at the same time, let's not broadcast and tell people that we're giving everyone sepsis when actually he had a varice that bled. And so that's, why to think about what we're documenting and not just use a quick trigger to call everything, especially in the field of sepsis where it's an area of focus. There's probably 6 different quality metrics that incorporate sepsis in some way that go into our STAR CMS rating. So being cognizant of what we think and what we call sepsis just helps us represent who we really are and the quality that we provide. So I will pause there and offer one more opportunity for questions before we transition over to Team Hall.
Justin, what do you do in the case where a patient comes into the emergency room and does look toxic? So oftentimes by the time we're seeing them, it's 4 or 5 hours into their care. And if they've gotten appropriate resuscitation and appropriate antibiotics, they might have turned a corner and potentially no longer look as sick as they did. So would you say sepsis resolved or impending sepsis, or how do you handle that case when they seem to look different clinically than they did when they first showed up?
Yeah, probably a little bit depends on sort of how different they look, but using the word that you said, they looked toxic. If they looked toxic and the ER was really aggressive in doing the resuscitation, and you are looking at this patient and think that they are likely to be in the hospital for several more days, then I think it's okay to call that sepsis. Technically, yes, you could say it was sepsis on initial presentation and resolved, but just calling it sepsis would be fine. And, where I'm thinking with talking about was, the degree of toxicness is they were confused and encephalopathic, but we did minimal and they got back to normal versus, yeah, they were really ashen and toxic and they got full 3 liters and full broad spectrum antibiotics and trended lactates, really aggressive management, then yeah, I think that supports saying that patient was septic, and we, fortunately did a heck of a job and helped them turn the corner. Although I suspect those patients you still have a concern for. They look much better, but you still have a concern that something could happen to them over the next 12 hours if we aren't staying on top of their care, where some of those simple UTIs, you're like, yeah, she's going to be okay. We'll watch her overnight and go from there. Does that kind of help?
Yeah, overall, I think this was really helpful. I feel like all of this stuff was meant to be attuned to sepsis, but it is sort of translated, and me included, into just calling everything sepsis because it sort of felt like that's what we were supposed to do, and that it became a checklist and not, and our clinical reasoning sort of went out of it. So I feel silly sometimes with the things that I'm labeling as sepsis because it just feels silly. So so thank you, because this is really, really helpful and very empowering to sort of go back to how we, to really characterizing the patient based on our clinical judgment and not them just meeting a checklist of certain vital signs and lab abnormalities.
Absolutely. Well, thank you everyone for joining us this evening. And, certainly welcome to answer any questions as they come up, particularly as the new queries come out. If they're confusing, the queries should include the contact information to contact the CDI nurse, which is always great. But if you also want a provider perspective on it, I am generally, well, I'm always happy to help out. I just hope it's not in the middle of the night, but All right. Well, see everyone over at Team Hall.